Hey everyone, and welcome to sqadia.com. Today we'll be talking about oral squamous cell carcinoma. So it is the most common malignant neoplasm of the stratified squamous epithelium. It usually involves the lip and the oral cavity, and it is said to be the fifth most common type of cancer in the world. So now let's look at some of the etiological factors which are involved in the squamous cell carcinoma. Now, first of all, we need to understand that there is no single causative factor. It is a multifactorial process, meaning a lot of different etiological factors come together and play a role in the development of the tumor. First of all, let's talk about tobacco smoking and smokeless tobacco. Products like pipes, cigars, cigarettes, BDs, and reverse smoking. BDs, in this, tobacco flakes are rolled up in a leaf, and it is said that it is 3 times more harmful than normal cigarette smoking. And reverse smoking literally means reverse smoking. In this, the burning end is held inside the mouth, and this causes a lesion on the hard palate. So tobacco contains around 70 carcinogens, including nitrosamine, arsenic, benzopyrene, and benzene. Now, these carcinogens are going to produce free radicals and oxidants. And what these free radicals and oxidants do is that they counteract and destroy the good endogenous antioxidants inside our body. Betel quid or pan. The areca nut, which is present inside the betel quid, is one of the ingredients, and it is carcinogenic. It causes a leukoplakic lesion, which is a premalignant lesion. Alcohol. In chronic alcohol users, the oral epithelium becomes more permeable to the action of ethanol. Ethanol is eventually metabolized to acetaldehyde, and this is basically a carcinogen. Some other factors like nutritional deficiencies also impair the mucosal barrier. And in case of a liver disease, the liver is not able to detoxify the carcinogens, so the harmful effects of the alcohol just keep on doubling. There is always a risk of developing a cancer in immunocompromised patients. Diet and nutrition. Iron deficiency is associated with Plummer-Vinson and Peter-Kelly syndrome. And this has said to have an increased risk, which is associated with esophageal, pharyngeal, and the oral cancer. Now, iron is very important in maintaining the oral epithelium. Vitamin A, C, and E. These are said to reduce the risk of developing the oral cancer. So guys, make sure that you're taking your fruits and vegetables. Now, if there is deficiency, there is going to be atropic changes. Thinning out of the epithelium makes it more susceptible to carcinogens. Bacteria and fungi. Streptococcus, Neisseria species, and Candida albicans. All of these have the ability to convert ethanol into acetaldehyde. And like we discussed before, acetaldehyde is the carcinogen. Also, in some of the periodontal diseases, the bacteria induces the production of pro-inflammatory cytokines. Pro-inflammatory cytokines are basically the cytokines which upregulate the inflammatory process, which enhance the inflammatory process. So what happens is that the cell proliferation increases and the apoptosis, the programmed cell death, decreases. So that causes an imbalance in the cell division. Also, a type of leukoplakia known as candida leukoplakia is a precancerous lesion, and it increases the risk of developing oral squamous cell carcinoma. Next is oncogenic viruses. Some of the viruses, like the human papillomavirus, has a high specificity to the epithelial cells, and the HPV virus 16 has an oncogenic potential. So what a virus does is that it inserts specific DNA fragments into the host cellular genome. This causes the functions of the tumor suppressor factors to be eliminated. Some of the functions include apoptosis, DNA repairing, cell cycle regulation, and cell immortalization. So if there is an imbalance, this is going to cause abnormal cell division leading to a tumor development. Then we're going to talk about immunosuppression. In immunosuppression, the immunological surveillance is affected. The immunological cells are not able to identify the malignant cells and destroy them at an early age. So they just keep on dividing without any check. Especially in patients who receive immunosuppression therapy prior to transplantation or individuals who are infected with the HIV. And also if there is exogenous carcinogenic use like in cigarettes and alcohol, this is just going to increase the risk for developing the cancer. Next is oncogenes and tumor suppressor genes. Tumor suppressor gene, the p53 gene, has some very important functions. These include cell cycle progression, cellular differentiation, maintaining the genomic stability, DNA repair, and apoptosis. To remember these functions, there is a mnemonic, a small mnemonic: cells can maintain DNA. This is really easy to remember. Now, the p53 also plays an important role in the cell cycle control. Now, there are 4 phases when it comes to the cell cycle. Number 1 is the G1, the growth phase. Then is the S phase, DNA synthesis. G2 phase is the preparation for mitosis, and then there is the M phase where mitosis occurs. Now there are 2 checkpoints. One checkpoint is between G1 and S, and the other one is between M and G2. So if the p53 gene is not working properly, these checkpoints are not going to, there's going to be faulty checking at these checkpoints. This means that if there is a damage in the cell, it is going to go unchecked and eventually it is going to turn into a mutation and all of the cells are going to divide the same way. Also, the proto-oncogenes are converted to oncogenes, usually by the action of viruses or carcinogens, just like we discussed before. And these oncogenes, these are going to cause uncontrolled cell division, which eventually leads to a tumor production. Now, let's talk about the pathogenesis. First of all, there are some etiological factors just like we discussed previously, cigarette smoking and alcohol consumption. These etiological factors cause DNA damage. Now, either the damage is repaired or there is a failure to repair this damage. If the damage is not repaired, then the mutation is going to carry on. One of the 3 things may occur: activation of growth-promoting genes, the proto-oncogenes. Then there is the inhibition of the tumor suppressor genes, which includes RB gene and the p53 gene. Then there is also going to be defected apoptosis by the RAS gene. Now these 2 factors combine together and cause an increased cellular division. Now let's talk about the oncogenes first of all. Just like we discussed before, the oncogenes are derived from cellular proto-oncogenes. What are proto-oncogenes? These are basically the proteins which encode and mediate the signals for cell growth. So if there is a carcinogen involved, there is going to be mutation in the DNA. And the oncogene is going to promote cell proliferation by overriding the checkpoints, which we just discussed before. By overriding these checkpoints, the mutation is going to stay inside the cell, and that defected mutated cell is going to keep on dividing. Then we're going to talk about the tumor suppressor genes. In the tumor suppressor genes, we have the RB gene. This RB gene regulates the cell cycle, specifically the G1 to S phase. The hypophosphorylated RB gene makes a complex with the E2F transcription factor. Now, when this happens, there is going to be inhibition of the E2F mediated transcription. Transcription is basically a step which occurs in cell division. Now, if there is a mutation in the RB gene, it is going to convert into a hyperphosphorylated RB gene. When this occurs, the E2F RB complex is going to dissociate. This is going to activate the transcription and eventually lead to cell proliferation. The p53 gene. The tumor suppressor gene plays a role in the cell cycle progression, cellular differentiation, DNA repair, and apoptosis. And if mutation occurs in the p53 gene, all of these functions are going to be affected and eventually going to lead to uncontrolled cell proliferation. And lastly, we have apoptosis. Apoptosis is the programmed cell death. There are some important regulatory molecules. These are the pro-apoptotic genes, the BAX and the BAC gene, and the anti-apoptotic genes, the BCL2 and BCLX genes. Now, in case of oral squamous cell carcinoma and oral dysplastic lesions, there has seen to be an increased expression of the anti-apoptotic genes. When this happens, there's not going to be effective apoptosis and there's going to be excessive cellular division. Now, let's discuss some of the common sites where the oral squamous cell carcinoma may occur. The most common site is the tongue and the floor of the mouth. Now, these two sites combine to make about 50% of the cases. Floor of the mouth, usually it arises from a leukoplekic or an erythroplekic lesion. Other sites may be gingival or alveolar mucosa. Usually in these cases, it may invade and erode the underlying bone and cause tooth mobility. Hard and the soft palate, and the buccal mucosa. Now, people who use betel quid usually have the buccal mucosal involvement. Now, the tongue and the floor of the mouth. These two sites account for about 50% of the cases. This is because the thin, non-keratinized epithelium allows the penetration of the carcinogens. This is an epithelium. The top layer is the keratin layer, and the layer just next to the basement membrane is the basal layer. So, the carcinogenic agents can reach the progenitor cell compartment of the basal cell layer of the epithelium. Now, the progenitor cells are the parent cells from which all the cells are produced. So, if there's a malignant transformation in the progenitor cell, that is going to carry on in the rest of the cells as well. Now, let's move on to the clinical features. The oral squamous cell carcinoma in the early stages usually appears as a non-healing paleness ulcer. A suspect usually arises if the non-healing paleness ulcer lasts for more than 6 to 8 weeks. Other than this, it may appear in the form of an erythroplakic lesion. This is basically an early lesion and it appears as a red velvety textured. It shows moderate to severe dysplasia. It may also appear as a leukoplakic lesion. Mild to moderate dysplasia, the leukoplakia may vary from a thin white plaque to thick, nodular, or even verruciform papillar leukoplakia. In some cases, both of these lesions coexist and it is known as erythroleukoplakia. It may also appear as an exophytic lesion, an irregular papillary mass. As we can see in this picture, there is an irregular mass on the lateral border of the tongue. The color may vary from normal to white or even red. There is presence of surface ulceration. It may be hard or indurated on palpation. Now, the color variation is due to the amount of keratin production and the vascularity. Endophytic lesion. Endo means inside. So, this is a centrally depressed, irregular shaped ulcer which has rolled borders. Just like the pizza slice has rolled borders, we can remember this by this picture. The rolled borders may be pink, red, or white. Now, why does that happen? This occurs because there is invasion of the tumor downward and laterally into the adjacent epithelium. Now, this picture helps us to understand how the tumor invades. As we can see that this is the tumor and this is the epithelial cells. The tumor eventually erodes the epithelium and enters the blood vessel. Now, it may be also indurated or rubbery hard. This is also because the carcinoma has invaded and the oral mucosa loses its normal elasticity. Lip crusting or ulceration. Usually in cases of actinic cholosis, this is a premalignant alteration of the lower lip vermillion. This occurs due to the harmful exposure of the UV light. And usually it appears as a non-healing ulcer, which may be less than 1 centimeters in diameter, so it is diagnosed at a very later stage. Other features include induration. Just like we discussed before, this is the rubbery hardness, and it occurs due to the invasion of the carcinoma, which results in the loss of normal elasticity. Fixation to the underlying structure. This basically occurs due to fibrosis. Tooth mobility is seen in those cases where the underlying bone has been eroded. On the radiograph, it usually appears as a moth-eaten appearance with ill-defined radiolucency or ragged margins. Now, paresthesia. Paresthesia occurs due to the perineural invasion when the tumor has invaded the nerves. Usually, the mental nerve is involved. So guys, this was part 1 of the oral squamous cell carcinoma. Keep a lookout for my second video.